Welcome to this high-yield explainer focused on mastering the differential diagnoses of inflammatory bowel disease and other chronic colitis. If you're prepping for the United States medical licensing exam, or honestly, if you just want a rock-solid structural understanding of gastrointestinal pathology, you are in the exact right place. We're going to take some pretty complex clinical presentations and break them all down into clear, highly testable concepts. Okay, let's dive right in and get started with a classic clinical scenario to really anchor our learning. Meet Gary Leonard. He's a 32-year-old guy presenting with an 8-week history of bloody diarrhea, abdominal cramping, and a pretty notable 4-kilogram weight loss. So he gets a colonoscopy, and it reveals severe ulceration of the distal colon. But here is the absolute most crucial part. The mucosa is granular, friable, and erythematous in a strictly continuous fashion, starting right from the anal verge and extending about 15 centimeters proximally. The rest of his colon, totally normal. So here's the question I want you to just keep in the back of your mind as we go through this explainer today. Is this Crohn's disease or ulcerative colitis? By the end of this, we are going to build the exact diagnostic framework you need to answer this kind of presentation with absolute confidence. Here is our roadmap for today's explainer. We'll start with IBD pathogenesis and epidemiology. Then we'll do Crohn's disease highlights, followed by ulcerative colitis highlights. After that, we'll hit IBD complications and serology, touch on IBS and microscopic colitis, and wrap up with diversion colitis and GVHD. All right, let's jump straight into Section 1, IBD pathogenesis and epidemiology. The demographic and genetic data for IBD is incredibly high yield for board exams, so let's unpack it. First off, you've got to note the bimodal age distribution. IBD doesn't just have one primary age of onset. It actually peaks twice. The major peak hits young adults between 15 and 30 years old. But there is a second, smaller peak you've got to watch out for in patients between 50 and 70 years of age. Next up is the hygiene hypothesis. Now, this sounds kind of counterintuitive at first, but IBD actually appears to be a disease of cleanliness. Basically, multiple childhood exposures to enteric pathogens seem to protect an individual, meaning poor sanitation literally has an inverse relationship with your risk for developing IBD. Crazy, right? Finally, we have to talk genetics. Specifically, you need to know the NOD2 gene. This is a massive buzzword for Crohn's disease. The NOD2 gene codes for an intracellular receptor that essentially recognizes bacterial cell walls. In a healthy gut, it helps create immune tolerance to our own normal gut bacteria. But when you have an NOD2 loss of function mutation, that tolerance completely breaks down. It triggers a cascade of inflammatory cytokines and boom, leads right to disease. Drilling down just one step further into the immunology, we have a very clean, highly testable distinction. Both forms of IBD are characterized by an aberrant immune response, right? But the specific pathways actually differ. Crohn's disease is driven primarily by a Th1 immune response. On the flip side, ulcerative colitis is associated with a Th2 immune response. Locking this fundamental difference into your memory right now will help you immensely when you're trying to untangle the varying systemic effects and pharmacological targets for these two diseases later on. T1 for Crohn's, T2 for UC. Moving right along to Section 2, Crohn's disease highlights. When we look at the gross specimens for Crohn's, notice how the transmural inflammation, and by transmural I mean it goes through the entire thickness of the bowel wall, leads to these deep, linear, knife-like ulcers. When those longitudinal ulcers are crossed by short transverse ulcers, you get that absolutely classic cobblestone appearance. It literally looks like a cobblestone street. Because the whole wall is inflamed, it becomes thick and rubbery, leading to strictures. And those strictures are notorious for causing painful bowel obstructions. You'll also see something called creeping fat, where the mesenteric fat wraps all the way around the serosa. It's almost like the fat is trying to hug the inflamed bowel. And microscopically, well, the absolute holy grail of a Crohn's diagnosis is the non-caseating epithelioid granuloma. Now keep in mind, these are only found in about 35 to 60% of cases. So actually, their absence doesn't rule out Crohn's. But if they are present, that is a massive slam dunk diagnostic clue. Notice also how the disease skips around. It leaves areas of totally normal mucosa sharply demarcated from the diseased sections. We call these the famous skip lesions. All right, Section 3, ulcerative colitis highlights. Let's see how it compares. The differences here are stark, and for exam purposes, extremely important. Looking at the pathology, ulcerative colitis is limited entirely to the colon. The small intestine? Completely spared. Furthermore, there are absolutely no skip lesions here. UC always involves the rectum and spreads proximally in a diffuse, continuous fashion. There's a sharp, unmistakable transition between the inflamed, bloody, friable mucosa and the normal tissue. Microscopically, unlike that full-thickness transmural inflammation we saw in Crohn's, UC is limited strictly to the mucosal and sometimes superficial submucosal layers. Because of this, the overall bowel wall thickness actually remains normal. Now, for your exams, the hallmark microscopic buzzword you need to have memorized is the crypt abscess. This is where numerous neutrophils accumulate right inside the lumen of the colonic crypts. You are not going to find granulomas, strictures, or creeping fat here. Just continuous mucosal-level destruction characterized by these neutrophil-filled crypt abscesses.
Let's move into Section 4, IBD complications and serology.
Okay, so the crucial point is synthesizing all this into a fast, reliable mental table. Let's just walk through it together. Bowel region? Crohn's loves the ileum, but can definitely hit the colon. UC is strictly colon only. Distribution? Crohn's has skip lesions. UC is a diffuse, continuous march right up from the rectum. Strictures? Very common in Crohn's, due to that thick, rubbery wall we talked about, but pretty rare in UC. The inflammation itself is full-thickness transmural in Crohn's, but limited just to the mucosa in UC. Granulomas? Yes in Crohn's, absolutely never in UC. Finally, a major clinical complication to differentiate the two, toxic megacolon. This is a dangerous, life-threatening risk that is primarily associated with ulcerative colitis, not Crohn's.
So, beyond the clinical presentation, how do we actually tell them apart with a simple blood draw? You need to memorize these two serologic markers, ASCA and PANCA. Anti-Saccharomyces cerevisiae antibodies, or ASCA, are classically positive in Crohn's disease. Conversely, perinuclear anti-neutrophil cytoplasmic antibodies, or PANCA, are positively associated with ulcerative colitis. So, if you have a patient who is ASCA positive and PANCA negative, that heavily points towards Crohn's, while the reverse, ASCA negative and PANCA positive, strongly suggests UC.
Now, despite all these nice, neat categories, medicine is never perfectly black and white, is it? In about 10% of IBD patients, there's just so much pathologic and clinical overlap that making a definitive diagnosis simply isn't possible. We call this indeterminate colitis. In these tricky cases, those exact serologic studies we just talked about become your main tool for categorization. But here is the critical takeaway. Regardless of whether a patient has Crohn's, UC, or indeterminate colitis, there is a massive shared complication you must know, and that is colitis-associated colorectal cancer, or CAC. The risk for this increases sharply about 8 to 10 years after disease onset. Why? Because years of chronic inflammation produces free oxygen radicals that just constantly damage the colonic epithelium. If this damage isn't repaired properly, it leads to dysplasia. And that dysplasia is an in situ transformation that eventually, inevitably, progresses to carcinoma.
Shifting gears a bit, let's look at Section 5, IBS and microscopic colitis. What if it's not IBD? First step in our mimics and differentials is irritable bowel syndrome, or IBS. It is absolutely vital to understand that IBS is strictly a functional disorder of the gastrointestinal tract. These patients present with chronic, relapsing abdominal pain, bloating, and altered bowel habits. Now, those habits could be diarrhea, they could be constipation, or a mix of both. But the absolute key differentiator here for your exams, and honestly for your clinical practice, is that IBS is a diagnosis of exclusion. When you run laboratory studies, take an abdominal x-ray, or perform a colonoscopy, the results will come back completely normal. There is zero structural or gross inflammatory pathology to be found anywhere.
Now, contrast that functional disorder with microscopic colitis. The clinical presentation here is typically a much older patient, median age is around 65, who comes in complaining of chronic, non-bloody, watery diarrhea. Much like IBS, if you do a colonoscopy on this patient, the gross endoscopic findings are completely normal. The mucosa just doesn't look inflamed to the naked eye. However, unlike IBS, when you take a biopsy and look at it under a microscope, you will find distinct, defining histological abnormalities. It comes in two primary flavors, which we are going to look at right now. Check out the difference between the two types here. In lymphocytic colitis, you see this massive, obvious increase in intraepithelial lymphocytes within what is otherwise a normal-looking crypt architecture. But now look at collagenous colitis. The absolute dead giveaway buzzword for this one is the thickened collagen band. You can clearly see that pink, significantly thickened band of collagen sitting immediately beneath these surface epithelial cells. Both of these types cause that frustrating, chronic watery diarrhea, and both show zero gross inflammation during a scope, but their microscopic signatures, totally unmistakable. We've made it to our final section, Section 6, Diversion Colitis and GVHD. Picture this. A patient undergoes a Hartmann's procedure for severe diverticulitis, or maybe rectosigmoid cancer. The surgeon resects the diseased bowel and creates a colostomy, but they leave behind a disconnected, completely unused rectal stump. Because the fecal stream is now diverted away, this unused segment actually becomes inflamed. Why does that happen? Well, it's thought to be due to drastic changes in the microbiome and the sudden lack of vital nutrients, specifically short-chain fatty acids, that the fecal stream normally provides to those colonic epithelial cells. Clinically, it presents with anorectal pain and bleeding. But the real magic of diversion colitis is that it completely resolves once the surgeon goes back in, reconnects the bowel, and restores normal fecal flow. It's essentially a starvation colitis of that stump. Our final condition today is graft versus host disease, or GVHD, specifically of the gut. This is a severe, often terrifying complication seen after a patient receives a bone marrow transplant, also known as hematopoietic stem cell transplantation. What happens is alloreactive T cells from the donor actually go rogue and attack the recipient's healthy tissue. In the GI tract, this manifests as severe abdominal pain and massive, high-volume watery diarrhea, usually about 3 weeks post-transplant. Endoscopically, you might just see some nonspecific edema and shallow ulcers. But in the biopsy, the ultimate board prep buzzword you need to sear into your brain is numerous epithelial apoptotic bodies in the crypts. If you have a post-bone marrow transplant patient with watery diarrhea and apoptotic bodies in the colonic crypts, you are dealing with GVHD. Full stop. So let's bring this all full circle right back to our opening case. Gary Leonard had bloody diarrhea and a colonoscopy showing continuous granular friable mucosa starting exactly at the anal verge and moving proximally without skipping a single inch. Based on the diagnostic framework we just built together, what is the definitive diagnosis? It's classic ulcerative colitis. The continuous nature of the lesions, the origin firmly in the rectum, and the limitation to the mucosal layer point squarely to UC. It completely bypasses Crohn's and the other minor colitises we covered. You now have the visual and structural tools to master this differential on any exam. But I want to leave you with this final, somewhat provocative thought. As we continue to uncover the wild intricacies of the gut microbiome and genetic factors like NOD2, are we approaching an era where we stop classifying IBD simply as just Crohn's or UC? Are we instead going to start treating them as a vast, complex spectrum of individualized microbial dysbiosis? Something to think about. Until then, keep this framework in your mental toolkit and happy studying.